Hello, everybody. There was a little bit of a confusion to get this started. I want to welcome you all to Treating Trauma with REBT, and I'm Dr. Steve Johnson. And this was an open time for people to ask whatever questions they want and respond to each other, etc. I've set aside an hour for this, but if we don't need that time, that is perfectly fine. So if there are questions, I can take those. You just enter the chat, and then we'll go from there. If there are no questions, I do have some that were posed to me, at least they were messaged to me on Facebook, so I can begin with those. Okay, and I will keep an eye on any of the chats in case people do respond to that. So one question was, there are two major categories of PTS treatment that have really strong research support. Those are presence-centered therapies as well as exposure-based therapies. Which category does REBT fall into? And it's pretty excellent question. And the answer to that is REBT, as I think of REBT, kind of bridges those two treatment categories, because in the presence-centered therapies, what we see are techniques for dealing with symptoms of the PTSD, for example, high anxiety, etc., in the present. So they give them kind of tools for how to do that. They don't go back and try to do any imaginative exposure or reliving the traumatic event. They don't do that at all. In fact, for example, in Seeking Safety for PTSD and Substance Use Disorder, developed by Dr. Lisa Najavitz, it's kind of understood that they will not engage in going back to the activating event or the trauma. So REBT does have that component. And as for exposure, yes, REBT does exposure. REBT does exposure not only for trauma, but for anxiety disorders, for depression, any number of conditions. So if we think about PTSD, it used to be kind of located within the diagnostic category of anxiety disorders, and now it is in a separate category called PTSD and other trauma-related disorders. That doesn't mean that there's not an inordinate amount of anxiety in PTSD. So we can, of course, we're going to use those techniques, and including exposure techniques, to deal with that anxiety, because anxiety is typically associated with avoidance. And so we would want clients to overcome the avoidance in helpful ways. So in many ways, as I said, REBT is kind of a bridge between presence-centered only and exposure-only forms of therapy. I hope that was a good response to that one for you and clarified what you were thinking. I'm still looking for individuals to enter any kind of question or comment into the chat. We don't have any yet, but there were several other questions, so I will go on. This next one is just a fascinating question, and actually one that I've been thinking about for quite some time. And it says, does REBT integrate attachment theory into understanding and treating individuals with post-traumatic stress disorder and other trauma-related disorders? Well, attachment theory itself is not a major component of REBT. However, attachment is tremendously important, and we need to consider attachment. Now, I don't know of any therapist who denies attachment. Do we necessarily use some of the existing attachment theories? Well, I'll tell you what I tend to do rather than going to attachment theories. And look, I have nothing against attachment theories. I think they can be quite helpful. But I tend to go to the ACEs score, those adverse childhood events or experiences, and look at those because those have been correlated with any number of mental and emotional disorders, and both physical and emotional, mental and emotional disorders. So early history and any early traumatic event or neglect or abuse is tremendously important and may come up within therapy because they serve, those events serve as the context and as the activating event for which individuals create their beliefs and inferences to try to make sense out of what they went through and to kind of negotiate that. And so some of those beliefs are going to be about the self. They're going to be about others. They're very definitely going to be, and attachment theory brings this out in the open, very much about relationships between the individual and other individuals, which is extremely important. And then also, it will have to do with the inferences about whether the environment or others are safe or hostile. The same thing with the world. Is the world a safe holding environment, or is it hostile, or some combination thereof? Let me give an example. One kind of attachment style that is often talked about in attachment theories is an anxious avoidant attachment. Well, REBT would go, yeah, that makes sense, that when an individual is interacting with another individual, they may respond with anxiety or with with avoidance. And so of course they have an anxious avoidant attachment. So we would say that's the reality. Now how we might go about it might be different than some attachment theories would engage in the treatment. We would say with anxiety, we know with anxiety there are inferences and beliefs and action potential, and one of those action potentials is avoidant. So anxious avoidant attachment makes perfect sense for us, but we would probably do some cognitive restructuring and exposure to try to help them. I just had a question. Let me see. Is it good to do cognitive restructuring imagining past traumatic events? This is an excellent question, and it's there's a split in the treatment community. I will respond to how I do it, but you may get other REBT therapists that handle this in a different way. And believe me, what we do with an individual client may deviate from some kind of ideal or manualized approach because it's really what's working with the client that is really, really important. I initially often will try to help the individual become less physiologically aroused. And so we can look at kinds of relaxation techniques, even distraction techniques. Let me give an example. In Lisa Najavitz, who has a excuse me, presence-centered treatment model for PTSD. And as a present-centered treatment model, they do not go back, even imaginatively, to the past. However, if we go to a more exposure-based, then we would see that they would use the imagination for the individual to re-envision being in that situation, and sometimes they will involve, for example, with EMDR, CBT-like approaches that might involve changing cognitions, etc. I can't speak totally authoritatively with EMDR, although my daughter's a practitioner of that, and I've talked to her quite a bit, and I feel quite I feel very highly about that model. So, to get to that question, which is really a good one, I would begin generally, and it would depend upon the physiological arousal level of my client. If the client is highly physiologically aroused, I may not begin with cognitive restructuring with imagining the past. What I might do is if they have events that trigger them in the here and now, then I might look at what they were thinking about that, along with kind of techniques for calming themselves down. One of those calming techniques for calming someone down, particularly useful in early treatment of PTSD, especially when trauma was really severe and the individual tends to be hyper aroused and physiologically aroused, then I would engage in something like grounding exercises, perhaps. And then once we get some skills built up, we kind of can handle the anxiety better. Then I would probably begin to do some exposure based. But I would really be timing that and seeing how the client is dealing with triggering events in the present before going to the past. Again, contingent on the contingent on how the client does. The reason for that is when I look at the outcome studies for using exposure-based therapies versus present-centered forms of therapy, exposure-based therapies tend to have a higher dropout rate. And often, if you think about it, it is because that exposure can be emotionally um, uh, triggering. And so the individual may have, huge amount of anxiety that arises. So I do like having them get some skills so that they can handle that a little bit better. Do that in more recent events rather than the major traumatic event from the past. Get some facility there, and then probably move more into um, the exposure of the past after they already know how to do some cognitive restructuring. I hope you found that a helpful answer. Let me see. Are there any other questions? If not, I think I've covered uh, one other thing, though, I didn't get when I was looking at about REBT integration of attachment theory or non-integration of attachment theory into the treatment of PTSD. There was a point there that I wanted to make and I didn't get to it, and that is when I'm working with the client, I will also spend with PTSD, I will also spend a good amount of time looking at the client's inferences. Now, I know most individuals who practice REBT or may have heard that REBT is all about cognitive restructuring, and that what we're restructuring specifically would be the beliefs and not the inferences. It's not quite true, although we would tend to see those beliefs as the direct cause or the predominant cause of the emotions and behaviors, largely because we could have one inference with multiple beliefs attached to that and then have different emotions. So clearly, the inference is not going to be causing the emotions directly. However, the inference is highly relevant, because if the inference wasn't there, then we wouldn't see that the anxiety or whatever. So one of the things that I like to do with individuals with PTSD, this is true also for any kind of condition that has a high degree of anxiety. For example, borderline personality disorder, even major depressive disorder, because there can be some anxiety associated with that, or generalized anxiety disorder, any number of conditions that have a high level of anxiety, is that I do spend some time working at the level of the inference. Why? And I'm curious about whether you guys do that too. If you work with people with trauma, because sometimes people will see that activating event, that trauma from the past, as this overwhelming threat that knocks out any possibility of any opportunity in their life thereafter. What I would like to do is help them see, yes, that was a threat. Was it an overwhelming threat that negates all potential future very negative event in the past? We wouldn't wish that on anyone else. And if they want to see that event in the past is horrible, okay, many people in RBT would say that we are against awfulizing. But if they want to see that as a single awful event, and they're not going to awfulize it about, ongoing way throughout, throughout their life, not so problematical. But to see this as an extremely negative event, but that there are still great opportunities in life for meaning, purpose, and potential happiness as we build our values and we become clear about the values that we want to attain and our goals for attaining them. So, yeah, that idea that event, the trauma, was an overwhelming threat. We really would like to move beyond that so they do begin to see opportunity in relationships with others. And relationships with others is really, really crucial because one thing that we do know, when an individual experiences a very negative event or trauma, when we see the sympathetic activation there, the body begins to produce cortisol from the adrenal glands, right? The cortisol is produced, which is the stress hormone, and can have in the long run a deleterious effect. In the short run, it is helpful. It prepares us to deal with the stressful event or the negative event because we're perceiving the environment. The brain is perceiving the environment as a threat. Something in the environment is a threat. So that is physiological arousal by the sympathetic activation system is really, really important. But it's not helpful in the long run because of the cortisol production that begins to cause some damage within the body. But we do know that there is one chemical that will negate the effect of cortisol, and that's oxytocin. And we humans experience like a burst of oxytocin when we are in close relationship with people and connected with them. So I think it's really important when somebody has trauma that we begin to give some behavioral interventions that have them connect with people as much as possible in safe ways, so that oxytocin level, that oxytocin level can increase and make them less reactive and less driven by cortisol. Okay. Okay. Someone said thanks for the answer. I'd like to then look at another question that someone posed to me, and if anybody has a comment that they want to make, feel free to do that. This one is, I'm really impressed with the questions that have come in. They're really top notch. And one was, can mindfulness be used with REBT in the treatment of PTSD? Absolutely. I think the treatment of PTSD necessitates the inclusion of mindfulness practices. I think most people do. There may be some who don't, but mindfulness is really helpful. Would I say that mindfulness is the silver bullet? No, I wouldn't say that. Mindfulness is tremendously important, but we do want to include mindfulness in the treatment. However, if the client comes in and they're really hyper aroused, something just happened, it might be better, instead of engaging in a mindfulness activity right then, to engage in grounding exercises that would distract them enough so that they're less physiologically aroused, and then we may be able to do a mindfulness exercise. I think the other thing is between sessions to help clients begin to have, incorporate mindfulness into their lives in all kinds of areas, like mindful eating or mindful exercising or even mindful watching television, so that we begin to squeeze more out of the experience. I think mindfulness helps pull us out of our head in many ways and into the body, which is so tremendously important. One thing that research shows that makes mindfulness invaluable in treating PTSD, especially if individuals who have PTSD also experience major depression, and that is when there are two major brain systems. One is called the kind of a positive system. It's kind of focused on when we deliberate or we're thinking about something or we're planning. And then the other one is the default mode network. And the default mode network is triggered when we're not focusing on problem solving, etc. So what happens with some individuals, and we see this in PTSD, we see this in depression and other conditions, is that when the default mode is activated, that individual's life within their head is more real than task positive when they're in the task positive mode, where they're really focusing on the world around them. And so if and they get stuck in that default mode network, that is the rumination that we see with depression going over and over and over. Well, from an REBT perspective, those dysfunctional beliefs. Can you imagine? This is terrible. This is terrible. This is terrible. This is horrible. This is awful. I can't stand it. This is too much. This should never. That ongoing narrative, when they're stuck in the default mode network, is not good. And so we want to help move them out of that. Well, it's found that the mindfulness techniques help detach the individual and get a better balance between the default mode network and the task positive network, because we want to balance there. We want an individual to be in task positive, but not all the time, because the default mode network has been found to be invaluable in the creation of the autobiographical narrative, and also for moral reasoning and other functions. So mindfulness is extremely important to introduce to get a better brain balance. So I know that's a long-winded way to say I think mindfulness is invaluable. However, if the client is highly physiologically aroused, I think I give them grounding exercises so that they can have the cognitive presence to then begin to use those mindfulness exercises, and they build a habit of beginning to experience the world in mindfully. Okay. So, any other questions or comments? Any other responses? Not seeing any more right now. But two other, let's see. Oh, here's one. Is it good to imagine healthy negative emotions and adaptive behaviors in the past, to give yourself another chance in imagination to oneself to find meaning? Let me read that again, because that one is a jam-packed question that is absolutely fantastic. Let me read it again. Is it good to imagine healthy negative emotions and adaptive behaviors in the past? So we're re-envisioning right now what happened in the past. To give yourself another chance in imagination to oneself to find meaning. I think this is an excellent question. And probably because I'm working with a psychiatrist right now on just this kind of thing. This is the very thing that we're doing, and we're beginning to train individuals, therapists in this approach. I think what we often will do, what we can do, and for me this is kind of at the level of inference and belief. I would make sure that the individual has skills. They know how to do the emotional skill. When I say skills, emotional regulation skills, etc. What to do if they become inordinately physiologically aroused, all of those kinds of things. Practice mindfulness and use grounding when they need it, etc. But once we've learned how to conceptualize emotion with the client, and we've taught them how to do the cognitive restructuring, I think it is a great exercise to go back to the past and even spend time rewriting it, but rewriting it from a perspective of what if, and so we're engaging in what if thinking. What if I have the same event, but now I have the skills that I have now? How could I look at this event in a different way? Still recognizing that there was threat there, that it was certainly not pleasant, and we wish we had never gone through that. That's absolutely true. But and while I may have some emotions that over the long haul would not be helpful. It would have been normal then. But what could we do to see that past and practice using the cognitive restructuring, if I've got this question right, to use the cognitive restructuring so that as I think about it, then I have some more adaptive or healthy negative emotions. Why is this important? Because if I don't change my beliefs about that past event, and again, I'm not going to pretend that it was a good event. That would just be ridiculous, because let that negative event be a negative event, again, that we wouldn't want to wish on any, even our enemy, but begin to have a different relationship with it and think about it differently as we're moving on in life, so that we're not triggered when we think about that event with those dysfunctional beliefs. When I say dysfunctional, I mean unhelpful. I'm not pejoratively looking at that individual in any way whatsoever. What happens to them is unjust, right? And so we're not evaluating them negatively at all. We'll accept them unconditionally. But if we can look at that in ways where they have these healthy negative emotions and even behaviors toward that, so that when they have those healthy negative emotions, maybe instead of ruminating, they make a call to somebody, or they go out and mow the lawn, or they watch some television that they like, or talk to a loved one, so they're engaging in different behaviors than avoidance behaviors that they may have engaged in the past. And so part of my research is on doing that, and at the level of inference, to begin having that event in our past, to then see how we can have opportunities in our life now, even with that as a part of our history. Note, as a part of our history, not as the most significant event in our history. It is the whole history that is significant and definitive, not the event. Right? So again, thank you so much. That was just an excellent, excellent question. If anybody has anything else, then, or wants to make a comment, feel free. I had a very interesting question from someone. I think it was from one of our maybe more psychodynamic friends, which I love, because they kind of see things differently from us on some things. And often I think about, okay, we're using words. They have a different vocabulary than we do. By the way, I was trained in psychodynamic, for years, and practiced it. And so one of the things that I like to do is, when I'm talking to the psychodynamic, is to try to see how I would conceptualize the terms that they use. And so that's kind of what this question entails somewhat, if I got it correct. Isn't the treatment of PTSD all about interpreting the transference? Fascinating question, because it harkens back to kind of what we were talking about, attachment. Attachment has to do with my relationship with another person. And so clearly, I, having gone through a very negative event, and if I have formed particular beliefs about that event and people that were involved in that event, or that were the cause of that event or that trauma, then it might be natural for me to employ those beliefs when I experience someone else. Maybe it's someone I love, maybe it's a perfect stranger or whatsoever. So that idea that the client kind of transfers some dynamic of the past relationship as maybe a cognitive construct, or a cognitive with an emotion attached kind of construct, as transference. Yes. So I would look at what's called transference as what happens when I have formed particular beliefs in the past, and those are triggered, and I am experiencing another individual in similar ways to how I experienced that person from the past. I might call that transference. But is treatment of PTSD only about transfer? I don't think so. I think it might help me get at the inferences that the individual has, which is invaluable. So processing what I call that, what they would call transference, and what I would call the triggering of those beliefs, and then and applying those to interpreting the relationship that they have with someone else would be important. Now, they would, my psychodynamic friends would say that goes on in the session so that they might transfer on me. There may be transference and see me as the withholding or traumatizing individual. Yes, I think REBT would be excellent for that, because then we could look at what beliefs are triggered when they begin to experience me as the traumatizing individual. One, we know the inference. They are seeing me as threat. And then they have certain beliefs about that. And we can process that using that ABC model. So you see, what is called transference, we're not denying that transference. We just are interpreting that in different ways and using the ABC model to address that. Okay. So a couple of other questions have come up. This I think was related to the other question. Can this transform the trauma and change the traumatic influence in now, overcoming the negative influences now? I would say, when we use the word trauma, I think here we have to be a little cautious, because, and it's why I don't necessarily like the word trauma. There's an event, and then I have an experience. My experience is of that event as traumatic. Okay, so I like to focus on what the client's response is to an event, and if they are experiencing it as traumatic, I'm going to deal with that reality, their experiencing of that event as traumatic. Now, I do think that question that you just asked is, can this transform the trauma and change the traumatic influence? If we help them to use the cognitive restructuring skills and begin to look at that past event as a very negative event, that have more adaptive behaviors and helpful negative emotions about that. Yes, that is changing their experience of that event, not their experience at that time, but their experiencing of it now as they think back. So I would say experiencing the event in memory may be different now in the present. So excellent question. Thanks so much. Can you talk about what happens in the brain during dissociation? How do you deal with dissociation that happens during dissociation? Very good question. I really, really like this. I just read a book again that I really like. It is called Narrative Exposure Therapy. And in the first few chapters of narrative exposure therapy, they have a very succinct neurobiological analysis, neurophysiological analysis of what happens when there is this event that is experienced as trauma, as traumatic. And so, of course, it begins with this, the sympathetic activation. And in the sympathetic activation, it's not flatline. It goes, it's just like a parabolic relationship, right? A curve. So the sympathetic activation goes up, cortisol is produced. We have these physiological experiences. There's called the uproar phase of that. When that peaks, at the very peak, before the parasympathetic activation kicks in, we see often dissociation. And I see dissociation as a wonderful way that the body has to be aware of what's going on in the environment, but emotionally detached from that, right? Like it is almost as if it's not real. And so it is kind of a helpful way for the body to adapt to that. Can you imagine if there was no dissociation there and you had to experience that just raw anxiety? That would knock your socks off. So I find that is, in some way helpful, but not in the long run. Not in the long run. And so there are a couple of things that people are talking about what could be done there. One is, how do we get them, right, to move from the sympathetic activation to the parasympathetic activation, or moving back toward homeostasis. So, and then we have the relaxation stuff, and we can have the clients engage in all of those kinds of things to kind of calm down. But I think also with the cognitive restructuring, over time, we may prevent that the parabola from going so high. Right? Maybe we lower the amplitude of that with practice and therapy. That is the hope. And then the other one is that we don't want to eliminate it. A lot of people say what we need to do is eliminate the sympathetic activation. Absolutely not. I mean, that is there in us so that we can perceive threat rightly. Now, the brain is always focusing on survival, so it may see threat when there is no threat. So you may experience needless anxiety, but you're still alive, because the brain will err on the side of seeing threat where there is no threat than seeing no threat where there is a threat, because you start seeing no threat where there's a threat, life, as one philosopher said, will be nasty, brutish, and short. So we want the sympathetic activation. We just don't want it lasting a long time, peaking so high. And so we have it, but the amplitude is lower, etc., and the base is going to be smaller. The other way to do that, I think, is we can lower, as I've already said, cortisol, and we can do that by being more affiliative with other individuals. We have very meaningful relationships in our life, and that can be a major protective factors. When we look at the protective factors for an individual with PTSD, people with PTSD, and even if they've never developed PTSD, tend to do better if they know how to form and maintain satisfying, meaningful relationships with others. So I think we need to do a lot of work in that area. And it's very hard. And I think COVID has been really difficult for us because it's kind of gotten in the way. But you know what? Even there, people have, even through the use of technology and, I know working with technology doesn't satisfy our skin hunger, is what I call it, but it can be can be helpful. So I think the dissociation can be helpful. Now, there are techniques for when a person is dissociated, right? One of the things we want to do is kind of pull them back into their body. And so some people say they just go to the refrigerator and pull out an ice cube and hold it for a while, and that will pull them back into the body. Some people take a pin or something like that. I mean, don't do this, but take a pin and just the point, so you get a little bit of pain, not a major pain, might help pull yourself into your body. But I think also realizing, not awfulizing about any short periods of dissociation, because this is your body's way to try to protect you from experiencing that raw anxiety. Okay. Irrational beliefs are connected to transference. Yeah, I do think irrational beliefs can be connected to transference. If we see transference as a negative transference, positive transference may not be interpreted in that way. But I would hope, I don't know, it's not in psychodynamics, but I would hope it would be a more realistic transference is what goes. And even, countertransference, I think we need constantly as clients to look at how we're responded to. So let's say my client, has post-traumatic stress disorder, and they see me, and they've had a traumatizing past. They were abused as a child, and so their ACEs score is really high. Then they may see me as, if they interpret something I said as a threat or a put down, see me as the withholding, punisher, traumatizer. And so, when they start treating me like that in the session, then I may kind of respond to myself emotionally. So it's really important for me to begin to look at when they begin to respond to me in that way, what are my unhelpful beliefs, and try to do some processing to get recognitive restructuring to get there so that I'm better able to help the client. And we can work through that. And that is just wonderful. That's bringing the ABC model right into the therapy session for both the client and for me. My subjective attitude to significant others is connected to irrational beliefs. Yeah, I think um, it is my attitude. Wendy would use that. Wendy Dryden would use that word attitude. Whether we use the word attitude or beliefs, it doesn't matter to me if we both mean the same thing. It is, yeah, I'm going to have a certain set of beliefs. Some of those beliefs are going to be really helpful beliefs. Some of them are going to be really dysfunctional beliefs. The same thing with inferences. If I'm inferring that you're a threat and I'm globally referring to you, thinking of you as a threat, or I'm globally experiencing other people as a threat, or I'm globally thinking of a particular group of people as a threat, then that will not be helpful for me in my relationships with other people and my engagement with life. So I think it is important for us to, we're not going to be perfect, and so of course we're going to have irrational beliefs about others and the self and the relationship between, but the degree to which we can hold realistic beliefs which would be more helpful. I can't remember. I thought it was Fran Lazarov, but I'm not quite sure. Who said that the goal of psychotherapy, um, is to accept reality as it is without unduly disturbing ourselves about it. And that is a goal, I think, to face the world, not like everything about it, not like everything about myself and others and relationships, but minimize the amount of disturbance that we engage in. Share work with traumatic from the past, healthy adult, wounded child. Um, I don't know. I don't do. I haven't done the wounded child work. I'm not certainly not against it. I've just never used that. The Gestalt empty chair, I think, could be done. Again, I don't know that I would start off with that, but I think once they do have some skills to manage mood management, to manage their anxiety, um, you know, take, in other words, kind of the self-care, take care of themselves. Once we're able to do that, and if we want to go to exposure, to do some exposure, I think the empty chair would be a great way to do that. The technique that we have in REBT that would come close to the empty chair is rational motive imagery. And so you might want to read up on rational motive imagery. Any book on REBT, just do a quick search to see if it covers rational motive imagery. And you can see how you could incorporate that into the treatment of somebody with post-traumatic stress at that point. Now, let me say something. There are clients who say they never want to do exposure therapy because that would be re-traumatizing. And I will honor that, you know. It's their life. I will go with it. I'm not going to do something that I can't agree with. But if they don't want to do exposure, that's fine. And I'm like, what if they're doing presence centered therapy? What if they know how to do cognitive restructuring, etc.? And so that when some trigger happens in the environment, they know how to deal with it. That's still a pretty good life you can have, right? Without doing the exposure. But there are other clients that say, "Duh, I don't want to foots with any of the present-centered stuff. Let me do the exposure." Okay, um, and I will give them some psychoeducation about it, about the dropout rate can be high. Initially, it can be uncomfortable, and etc. So I will cover, the potential consequences of that. But if they go that way, then uh, I might not do it, but I might, uh, refer them to someone who does practice those exposure therapies quite a bit more than I do. So, really good question. Um, for me, irrational beliefs and transference is a connection between REBT and psychoanalysis. I think so. I think there are so many models that once we get beyond the vocabulary, we can build bridges. And Albert Ellis himself was that way. He wrote a great book, and the name always escapes me. He co-authored it with Catherine McLaren. It's a really short book, And in it, there's one whole chapter in which Al and Catherine um, uh, really are building bridges between REBT and other models. So Al talks about how to build bridges with more psychodynamic, and he really singled out even object relations as one that he thought could really, really work. The vocabulary is different, and the approaches, all the not the interventions are not always the same, but there are confluences. Same thing with Gestalt. Same thing with person humanistic or person-centered forms of therapy. We can build these bridges. I don't know why we need to have wars with each other when we can build bridges. I want to share a story. At the Albert Ellis Institute, I was supervising somebody in a group in the primary certificate program, and one of the individuals was an addiction counselor who was trained in psychodynamic. And he said, this is the first time I've been exposed to this. I really want to look at this to see if there's something that I can incorporate into my psychodynamic model. And he said, I don't want to become an REBT therapist. I went, yeah, fine. And so when I talked to him at the end of that 3-day training, he said, this was really invaluable. And he said, I think one of the ways that I'm conceptualizing what you're doing in the ABC model is helping to bring about a positive transference. And so that can be helpful when there is a negative transference. I went, fantastic. He was able to do that integration piece. And I think that's helpful. In fact, I sometimes joke and say that REBT is predatory, not in a bad way, but for example, the empty chair. Al would incorporate that. I remember when I said because I was trained in family systems therapy, and we use the genogram rather frequently. And I said, Al, do you mind if I use the genogram? And he goes, why do you want to use the genogram? Especially when I was treating a lot of people with trauma. And I said, well, I don't want to just, come up with a family map, but what I would like to use is the genogram to trace irrational or unhelpful beliefs from one generation to another generation, because then I know how it's been modeled throughout the ages and how entrenched it is within the family system. And he says, go for it. Try it. He says, I really like that idea. And so that's kind of what we do. And that's how many of us who were trained at the Institute we're not real negative about other models. Is it good to use catharsis? Let me, for catharsis, say the word venting, okay? Do I think that it's always good to have the client engage in catharsis? I would like to answer that by looking at a couple of different things, and this will not be an exhaustive treatment of this issue. One, I don't want clients to just vent for the sake of venting, right? If they're showing the emotion because they would not allow themselves to experience the emotion, and they said that they absolutely should not show that emotion, I would love for them to get over that. Okay. On the other hand, would I think that it is curative in itself to do that? No, it would be helpful in that particular kind of case and maybe in some others. But we do know that venting anger actually, telling the kid to go punch a pillow or something like that, that kind of catharsis is not a good idea. That reinforces the anger. So I think we have to look at what we're doing in the catharsis and what the goal is of that. I don't know that a technique is good in and of itself, or that a practice is good in and of itself. I would look at what we're doing that for. Not against catharsis, as I said in that instance. I think if that becomes a way to unconditionally accept the self, that's a giant step. Releasing the emotions first and then cognitive restructuring. Again, all of these are really good questions. I don't know if I have a linear way to look at that. What I would like is to help clients become more aware of what their emotions are, and certainly not judge themselves when they have these dysfunctional emotions. Awareness, and learn how not to, globally rate themselves or put themselves down for having them, or see themselves as weak and out of control. Yeah, I would like to do that. So would it be nice to have an awareness of them? Absolutely, have an awareness of it. And because if they don't have awareness, it's going to be really hard to kind of do cognitive restructuring, because that C, right? The emotion would be the C in the ABC model. We need the C in order to figure out what the belief is, the B in the ABC model. And so yeah, it's important. I don't know if I would have it in a linear way that way. Okay. How does trauma impair memory systems? Oh, this is rather interesting. Um, we will let's look at a really basic level at this. And again, how does trauma impair memory systems? I think what happens is that, and I mentioned this earlier, often when an individual has, again, no fault of their own, gone through some major trauma, and they're hyper aroused, and they have this cognitive bias that the world is not safe. I've worked with some wonderful women who have been raped, and several of them repeatedly raped, and they were hyper vigilant and seeing potential threat, and sometimes they thought it was actual threat, when it wasn't. But that's the way they were dealing with the world, right? And so the environment became overwhelming threat. Makes sense. Then it's not helpful if that continues throughout life, and it disrupts relationships and intimacy sometimes, etc. And so one of the ways that we can help that is to help them change the inference. Again, the rape is a despicable event, not good, and there's no good involved in it. It is despicable. On the other hand, to globalize about the self, to globalize about the world and the environment is not helpful. And so we have that cognitive bias, and then we are seeking the environment for threats. That is a part of the brain function. The brain is a pattern seeking organ. Its goal, it is designed to see patterns, particularly patterns having to do with threat. And so, and that is practice. It is practiced over and over again. But frequently, the brain makes mistakes. Now, there are certain places where we see this. We see this in conspiracy theories. Often the individuals who embrace these conspiracy theories are interpreting threat where there is no threat, or erroneously interpreting threat, or globalizing the threat where there is no threat. So if we have the globalization of a false inference, that's not going to be helpful to the client, especially when you think that there will be irrational beliefs attached to that, which causes the emotion, and that is going to, that emotional response is going to be part of the memory, unfortunately, a part of the memory. And so that's part of what we're doing in therapy is working on that. Sorry. I just had surgery, and so my alarm just went off to tell me that I need to do my medication for that. But let me, yeah, someone is just thanking me for that. But thank you so much for that question about the memory system. There's a lot more to say there. And again, that text that I mentioned, the narrative exposure therapy, covers exactly that. So I really would highly direct you to that. There was one last question, and I left. if no one has a question, I had blocked off an hour, and then I need to take my medication and then call it a day. But you guys have been great. And this is a question that someone said: isn't trauma the source of substance use disorder? Okay. This is a complicated question, but I think it can be made really, really easy. And it is that when we look at PTSD, There are two major co-occurring disorders: major depressive disorder and substance use disorder. And when you think about the inordinate amount of anxiety, the constant hyperarousal, the seeing threat everywhere, that is so unpleasant. The anxiety, it's really, really unpleasant. So an individual may end up being depressed about it, especially with a lot of rumination. And then also, unfortunately, do some self-treatment and end up with a substance use disorder, right? Or even a behavioral addiction. So they're going to be co-occurring frequently. And in fact, when I treat somebody and the diagnosis is PTSD, I always check for major depressive disorder and, and the presence of any substance use disorder, and especially any minimization of the use of a substance and so forth. And I may get, with permission, the family involved so I get a better read on some of that information. So, however, trauma and PTSD is a multifactorial diagnosis. Many different factors come into play there: emotions, behaviors, cognitions, etc. And because of that, I don't know that there's a single bullet to say that it is and the same thing with substance use disorder. It is multifactorial. I just am at the uh, teaching a course in substance use disorder right now. It's free and obtainable for you through this channel. You can find all of those videos. But one of the things that I looked on in the early weeks was this multifactorial causal model for understanding, the predisposing factors or causes to developing substance use disorder. Trauma is one. It is not the one. And I think too often we're looking for a silver bullet when there is no silver bullets. There are multiple bullets, multiple causes there. So really don't like it when I hear people go, "Yeah, it's all about when the substance use, it's all about trauma. Go find the trauma." Well, if you're wanting to find the trauma and you think there has to be a trauma, you're going to find something that you're going to call a trauma, because that's a cognitive bias. I would refrain from doing that and really do a multifactorial analysis of the contributing causes there. There are protective factors too, and so many other factors that we need to look at, and what the irrational beliefs are about the trauma itself may predispose an individual to the substance use disorder and so forth. So thank you for that. There was one last question. I will do that, and then we will call it. It says, thank you so much for answering my question. Will the Ellis Institute conduct any training in trauma-informed therapy? Yeah, we have been. I can say that definitively because I do it, and I don't know when the next workshop on PTSD will be coming up, but there is a section in that on trauma informed and trauma informed therapy, because we really need to do that. And uh, what I like about motivational interviewing sometimes, and some of the techniques I think we can introduce into REBT, and some of them we already are. In fact, I talk about the overlap between motivational interviewing and how REBT proceeds rather frequently. And I think when we are dealing with someone who is traumatized, not only the therapist needs to be trauma informed, but all kinds of occupations do. For example, if you're a massage therapist, it might be helpful to know whether the person has been traumatized so that they don't misinterpret maybe something that you're doing. All kinds of, a dentist or any number of people probably need to be trauma aware, and so that they engage in trauma informed therapy. Yes, and we need to incorporate that when we're working with clients. So really good question. Okay. Let me see. I've got like 6 seconds, so let me see if I can answer that. Is logotherapy a good end of therapy. I don't know a good end of therapy. I like logotherapy, and often I really like the focus on meaning and um, and value in logotherapy. And so I do think, in fact, I'm looking at interviewing a practitioner of logotherapy and who also works with REBT, and for the two of us to discuss the overlap between logotherapy and PTSD. Thank you guys so much. I hope this was helpful for you at some level. And let me know. I'd like to hear from you on Facebook, on the REBT Education and Training site, and other sessions like this that we might engage in. Again, thank you so much, and you guys have a great rest of the day. Bye bye.